again, Basi, and thank you, John. Thank you, all of you, for having me on board. And I really apologize as a speaker. I felt really an embarrassing situation last time that we won't been able to have our session, but hopefully, like this date is somewhere we are started up with sharing my research and experience over the role of AI. Now, starting back to my slides, that's me. And I am, if you can go with my title is quite long. So it's the short form, Sayed and Rizvi. So actually, I'm an engineer. I did my computer engineering and that did my PhD in data science and AI. So I'm also the founder of Unexplained AI Limited, which is a newly found company this month. And we have our clients. Previously, I was working for somewhere freelancing, but I later realized that freelancing is not the solution. So we can combine a group of people, those who are working with me. And we started up working together. So I have 7 years of naval aviation experience and 8 years of HAI experience teaching in multiple universities back in UAE, Pakistan, China, and UK for the last 2.5 years. So this is my academic qualification, and moving forward, this is my affiliations. So I'm a treasurer and vice chair, as Jan told about me, of the British Computer Society, Coventry. And I'm also the member of Royal Statistical Society, professional engineer for Pakistan Engineering Council, professional member of Association of Computing Machinery, USA, and professional member of Institute of Electrical Electronics Engineer, IEEE, and also professional member of China Computer Federation. So I'm actually a bridge between East, which is China, Southeast Asia, Pakistan, and the UK. So I've been through multiple places, taught work experience with all those countries. So maybe I can deduce some of the good knowledge for all of the country, especially for UK, to bridge the gap between what has to be done. So my research area is actually the computer science, then artificial intelligence, then intelligent healthcare, and developing the knowledge graph. So if I move forward, today my talk is all about end-of-life support. So there's a story behind it. Somewhere my own sister was having carcinoma, and she was suffering from cancer. And although the stage is not that worst, but then when I came to know about this situation, I will start thinking about that what I can do, what as an AI specialist I can add into her life to do something more better, and just improving her life, supporting her till she alive. She's having her treatment, and I believe and need blessing of the people around me that she will get better soon. So then I started to work on finding some of the literature that is about the National Institute of Aging, which shows about palliative care and the hospice care. So let us take a difference between palliative care is somewhere when an elderly patient or any patient which has having last stages of cancer, they are probably going towards their end of life, and which every one of us should go, but they have something like before what they are anticipated or expecting something. So hospice is somewhere an environment they actually generate for the people, a special care unit in which they used to live. The people, those who are working there, that's actually different from the care houses. So they are actually having a special sort of support for those people, because a person who's suffering from cancer may lead to different sort of problems. Not even a cancer is a problem. There are a couple of problems which includes psychological disorders, a mental disorder, a speech disorder, it can be an eating disorder. So there are so many things associated with it, especially when a doctor just let you know that you're no more be here for after 2 months, 3 months, or after a year. So that is actually
palliative care and hospice care. What is the difference? Palliative care and hospice care are two types of care for people with a serious illness. But what's the difference between the two types of care? And how do you know which one is right for you or your loved one? Let's start with palliative care. Palliative care is specialized medical care for anyone living with a serious illness, such as cancer or dementia. Patients in palliative care can receive medical care for their symptoms, along with treatment that is meant to slow or stop their illness. The main goal is to improve a person's quality of life. The palliative care team works to prevent or ease suffering and help patients and their families make difficult healthcare decisions. Palliative care can be delivered in a hospital, nursing home, palliative care facility, or at your home. Hospice care is a type of care for people with serious illnesses who cannot or choose not to continue their treatment to cure or control their illness. While palliative care may occur at any time during a serious illness, hospice care typically occurs when a person has 6 months or less to live. Hospice care is similar to palliative care in that it aims to help improve a person's quality of life. It also helps family members cope with their loved one's illness and death. Depending on symptoms and end-of-life care wishes, hospice care may include services such as emotional support and spiritual support for the person and their family. Hospice care could also include relief of symptoms and pain and help with advanced care planning. Depending on the situation, it can be provided in the hospital, at home, or in a facility such as a nursing home. To learn more about palliative care and hospice care, visit www.nia.nih.gov/palliative-hospice.
So beside just the one I told you, my own inspiration related to doing any research over it, one of my students, she was in China, and we were discussing over doing some literature, some research work, and she talked about it that she also graduated in AI in like masters, and she asked me that I did each and everything, and what makes me to do or develop anything that can help people. I felt a little grief in her eyes, and then I start to investigate and ask some questions which cannot actually be very direct, but some indirect questions. So she told me that she shared her affection and love with her grandmom, and she was always living, but because the culture of China is something different from over here, people live with their babies, and after some time the babies used to live with their grandparents, and they actually grow them up. So that makes the kid to be having a strong bond with their great grandparents or the grandparents. So she felt that she lost her grandmom just because of she had an issue with the cancer, and because she was suffering in a cancer, so she won't be able to somewhere help her out. Although she realized that computer science has some of the, or most of the time, it has some very good connection with healthcare or intelligent healthcare, but she was still unable to find any solution for it. Then we started a project that working over the hospice care and the palliative care to start more work about it. So what I did is somewhere we moved forward, and then we found some of the statistics of the Office of the Health Improvement and Disparities, which is the UK government and official statistics, which is recently this year been released, shows that a new data of 2023 has been added, which shows that 5 places of death indicators have been updated. Each include data by ages, so from under the 65 years to 65 to 74 years, or 75 to 85 4 years. These are actually the brackets which actually they're set for. So this indicator describes that some people die in hospital, at home, in a care home, in hospice, or in other places. So during the COVID pandemic, there were also abrupt changes in the people death behavior. Initially, if you go back and learn something about the data science, so the basics of the data science has actually been invented in early 90s, which is by a John, which actually presented a bill of death or bill of mortality, so that he actually calculated the number of people, those who died from the plague, from the swine flu, from other diseases, pandemics, and then he actually made a centralized data collection. for the people, those who died, and also figuring out what had happened. So in recent percentages from 2023 compared to 2019, a higher percentage of people died at home. So they are actually believing that dying at home is much more easy and much more comfortable for them. A lower percentage of people died in hospice care because it's expensive. It has some flaws as well. People are not worthy. People are not having, I'm not actually blaming worthy. They are not very much trained for hospice setup. And a lower percentage of people died in hospitals compared to the previous years, although this represents an increase in the number of deaths in the hospitals. So before the COVID pandemic 19, so 22.5%, which is actually a couple of 100,000 people died in a care home. The rose is actually 23.6% increase from 2022 to 2023 and was 21.0%. So I have actually take a screenshot of all those trend, which led me to believe that people are still somewhere statically or somewhere nearby dying in the hospitals as compared to the home care and other places. So other places are not known, so that's why we cannot go with it. So we are always focusing about the hospital, home, care homes, and as well as hospice. So one of the major factor of doing this research is to improve the quality of the people, those who are living at home and they are at end of life support. So role of artificial intelligence is something, a debate, that how a role AI can involve into a person's end of life support. And that's what we are here. So predictive analytics using some electronic health records to identify the patients who can benefit from the palliative care, like they are consulting the people, they are going to the hospice referral, and they are being in contact with the healthcare setups. Again, one more thing is artificial intelligence can superficially look for the symptoms management, collect some data from the people of the patient, and predict and manage some symptoms like that. If this is the situation, how can we manage a particular symptoms? And finally, enhance the decision making, which is assisting clinicians and the families in making informed choices by providing them a data insightful decision making. So moving forward, we have UK statistics, which shows that approximately 90% of individuals who died in the UK would benefit from palliative care based on intermediate estimates, including contributory causes of death, certainties, and equating to around 600,000 people per year in 2021. So minimal estimates underlying the cost suggested that approximately 74%, which is 450,000 individuals, while maximum estimates could be a 96%. So projection includes by 2040 more than 7,300,000 yearly death will have palliative care need, which is a high number. So people are getting elderly, incoming an elderly bracket of more, and that's why they are having. And in even the increase of cancer, that makes us a situation in which we have to do something more about estimating the needs. So where do we actually need to collect the data? We can collect the data from hospitals and the local location of the death. In 2023, in England, for 2.8% dies in hospitals, 28.4% at home, and 21.0% in care homes, which actually I showed you earlier. So out of it, 55.1% in hospice care. Again, one of the biggest debate of the hospice care, that they are expensive. They're not, and even the hospitals are going to be expensive. But somehow, some of the things are to be cared by the government, or some of the things the patient should pay for that. So these proportions vary regionally. Hospitals' death range between 36.2% to 52.0%, and by age, with older adults more likely to die in the care homes. So where do we actually need to collect the data is continued over here. And then we have unrelieved pain at the end of the life. In England, an estimate of 436,000 people needed palliative care in 2023. Across the UK, 7,329 individuals, which is actually 20 people per day, died in their last 3 months without any pain relief. So they are keeping the pain, they are bearing the pain, but although the government or NHS is trying to provide a substantial a sustainable thing for them, but still there must be a need to develop something which can help them out. So only a 4.7% receive what is considered hospice level palliative care, or illustrating the significance unmet the need. And finally, we have access disparities. Over 100,000 people per year who could benefit from palliative care die without ever receiving any care, which is an alarming situation for us. Structured inequalities persist. Lower socioeconomic groups, non-cancer diagnosis, and ethnic minorities are also disproportionately underserved. So, patient demand analysis. So, personalized care plans. What we can do is to make a personalized care plans for the people, those who are being like a tailored plan for the treatment and support services to the individual needs and values. Although we cannot fulfill the demand of the people all the way, but at least we can make a maximum effort to cater their demands, and at least we can develop something which can help them out to mitigate those demands. So facilitating communication could be support, difficulty, conversation about end-of-life goals, and advancing care planning, and again, resource optimization for helping healthcare systems allocate staff and resources more efficiently to patients most in need. So the palliative care is actually depending upon these four major pillars. One is the advanced care planning, which they actually suggest what they need to do. Spiritual essential care, which like they are bringing the care people they are bringing to spiritual and essential care, and they are trying to help the person out of that particular stress. And then again, caregiver support, and finally the symptoms relief. So most of the time we always think about the symptom relief, that we can give a drug, we can give a medicine to the person to relieve, but it's not the only thing which can help us out. So if we move for centralized data aggregation, yes, it's one of the biggest problem. Although the NHS has solved this one, NIH also solved this particular thing, but still there are some gaps which needs to be fulfilled. For example, a national or regional palliative care data registry is developed by collating the electronic health record, hospice activity reports, demographic information, and clinical care outcomes. Still, what I have observed, I've been through a survey, and then I found that still there are some of the information at the hospice care or the care homes are not directly connected with the NHS services, so they are unable to see what's going on and how the patient has been treated. So we can develop a centralized approach in the previous slide, and then now we can make a relevant information extraction. Using the natural language processing and structured data mining technique, we can develop and extract some of the key information from an unstructured data or the clinical notes. So clinical notes are actually those notes which clinicians or surgeons or any oncologists used to give about the medicine, relief, or something about a patient. And we only need some of the information, not all the thing. If we go for text mining, yeah, again, this is a bigger job for each individual to extract the information. So we can just extract the relevant information using some NLP techniques. So finally, feature engineering from the extracted data. What do we need to do is to clinically meaningful features are to be selected only. This may include time series variables. For example, how much a time a person can spend in hospital and what resources, what are their risk indexes or comorbidity indexes, or what are the social determinant. And for example, like living alone or postcode linked deprivation index or any other disorder which is actually integrated with the data. However, in some cases, we actually ignore this particular sort of data, which is something very significant. So predictive modeling has a significant role in it. We can use some supervised machine learning model, for example, random forest, gradient boosting, deep neural networks, or the which actually we are suggesting is the graph neural network. And that has to be trained to predict individual level outcomes such as 3 to 12 months mortality. So we can make a class like from 3 months to 6 months, 0 to 3 months, 3 months to 6 months, 6 months to 9 months, and 9 months to 12 months, so that a particular outcome or particular result can be generated to help that patient out. Again, likelihood for unmet the palliative care needs. Again, it's a high risk trajectories requiring early interventions. So we are going to develop a model on the based on validated internally or externally using retrospective cohorts and performance matrices such as AU, ROC, precision, recall, and calibrate are reported once we are doing a predictive modeling. Again, the predictive modeling is not very accurate, but at least if we optimize this one, this might help us to help in decision making. So the last thing is the deployment. So we can develop a web-based clinical interfaces, for example, a secure web application designed as a clinician to help the clinicians enabling real-time access to the model, driving any predicted outcome, which are actually with the patient behavior, patient information. So that will help the individual patient summaries and automated decision support. This interface facilitates proactive referrals and care planning and makes the life of the person, those who are suffering, and the person who's caring both easy. So again, we can have some mobile applications for patient and family use. A parallel mobile application is developed to support patient-facing functions such as symptoms tracking, education and care navigation tools, direct communication with the care team, and enhance the engagement. So again, this will help, the mobile help might help the patient as well as the caregivers or the care team from the house to the hospice and towards the hospital. In that, it will help us out for engaging a patient, is self-management and timely escalation of the concern if there is some queries around. So end-of-life planning apps, there are already a couple of apps in the market. And especially those apps, I found that all those apps are actually limited to their regional behavior. For example, some of the apps are only work in US, some of the apps are only working in Australia. So for example, the cake, if I go with a cake, so again, this app helps user determine and share their end-of-life wishes. My End is actually an app which focuses on managing, directive, and facilitating end-of-life planning. And Healthy End-of-Life Planning, HELP, which is help. So this is an app designed to help carers and health professionals. Again, they are discussing each and every person on their own behalf. For example, people, those who are professionals, people those who are suffering, people those who are caring or bridging between those. So again, there's a concept which is missing over here, which is integration. So again, palliative care and the symptoms management app, which are actually helping us out, Help at Hand app. So this is a digital directory help app and available on mobile and online, provide access to the community, organization, and group that can help support hospice patient. So you can give your information related to the patient by patient himself or herself or by a carer. Again, another app is Wellmore Connect, and which helps to develop in collaboration with Wellmore Hospice Care. This is only a specific app for a particular care center, which provides you or allows you to have a communication between nurses and the monitor patients at home, and then bringing the patient completing their daily questionnaires about their symptoms, their situation. Likewise, a qualitative-based survey from a patient can help them out to assess what is the condition of a patient and how much care is actually needed to the particular patient. So the last one is somewhere the end of life care, which is a Microsoft micro care technologies. I'm sorry for the Microsoft, it's a micro care technologies. And this app provides a healthcare professionals with access to guidance, policies, and documents related to end of life. And even though it works without internet, so it's an offline app as well. So there are some more apps which like IZOT app and designed for independent use by patient and family members. Rockcroft app, web app, which is an app developed with funding from the Healthcare Foundation, focuses on enhancing patient care. And my PCL app, which actually I use, I downloaded somewhere using some other method. And then I started to read the particular app, that what is the structure of that app and how it actually works. It's a very interesting app and is specifically work in Tanzania, allowing patient and caregivers to complete a symptom assessment and submit it cloud-based server for review on healthcare professionals. And then the app will reply that how much is your symptom, what you need to do, where you need to go, whom you need to connect, and what are your further actions. So the last one is the End Well Care Live. This app is developed from Apple and is designed for end-of-life support. And unfortunately, this app is only working in US till my last research. So shortcomings, which actually I've identified in those current apps, is the fragmentation and lack of integration, which actually I discussed earlier, that many apps are serve narrow functions, only symptoms tracking, only information access, just they are looking for each individual app for every function. For example, if you need nursing care, you have to develop another, you have to download a new app. And for hospice care, you have to download another new app. So it's an integration sort of an issue that creates a fragmentation and sometimes overwhelming experience, especially for patient and carers already under stress due to their experience and end of life. So providing them a solution which is distributed might not work correctly. So if we are going with a gap analysis, I've been through the Cake app focusing on planning, while Velma app connects support symptoms tracking by nurses, where I found there is a limited crossover of data sharing between these two apps. So if you go with the shortcomings in current app, limited interoperability with healthcare systems. Some of the apps are still not integrated because they are private apps. So there is a need of a government to come up, or some public-private partnership to bring an app which can help the people to bring the palliative care patient information from their doorstep to the healthcare system. Again, there is a question of security, integrity, and the validation of the data. If somebody is providing and falsified information, that will be a clear issue. But somehow or another, if we go with a trend analysis, might be we can solve this particular problem. So electronic health records are one of the digital infrastructure used by the hospital and hospice care. If the relevant information has to be loaded through the app into the EHRs, it will help the particular patient in delivering the best experience before death. So this creates a duplication of effort, limits real-time updates between care providers and the patient. So what they need to do is they have to first upload it, and then the particular app can generate something, or still they need to give the information to the EHR again and again, which is a very frustrating situation. So gap analysis apps like MPCL submit data to the cloud, but do not necessarily feed into hospital workflows, which does not connect the healthcare service provider, and that's an instantaneous problem for a patient. The last one is the user. It's not the last one, I think so. It's the second last one, but probably user experience, UX, UI, UX is an emotional sensitivity is one of the, again, a bigger problem. All the apps which actually I studied, they have a multiple clicks, a multiple buttons to just press it up to find a particular relevant information. And the person who's already in stress, going to give his life, is not going in a situation that he or she might need to give multiple clicks to find a particular solution or search something or taking a help. Even though if a care person has been there, it's much more difficult for an ordinary person to handle such a kind of a difficult app. So a poorly designed can make an emotional complexity for the end of care life people or the patient. So this also can reduce the engagement. So what happens when we found the app is quite critical, it's not meeting our requirement. What we usually do, we actually leave the app. So this actually brings us to disengage with a particular app. And finally, the Cake, which is actually a Tinder style sweeping interface, may not suitable or does not suit to all the people, those who are facing decision about the death and dying. So again, lack of personal and cultural sensitivity, many apps offering generic templates or resources that may not align with the user's culture, religion, or individual values. So we have to think about it that if we are developing an app, within the UK, and we have a very diversified culture. We have to develop an app which can cater all the resources, all the things, all the people, and bring them into a single stream, so that they might not feel isolated. So reduced relevance and user trust in diverse communities. They think that we are the minorities, and so our needs are actually not very well calculated. So some of the way is gap analysis is planning apps that may not reflect or discriminated views on death, family roles, and advanced care directives as well. Unexplained AI, which is actually my company, and I have started this company recently, which I believe is revolutionizing the healthcare. While these apps are promising and fill important gaps in the end-of-life care, they often fall in shortfall in the integration of usability, accessibility, and evidence. A comprehensive, user-friendly, secure, and clinically validated pattern is to be introduced through this unexplained AI platform, and that brings the patient and the families and the healthcare professional integrated smoothly without having any problem, and that will help them out to be digitally connected with each other. So we are having a group of software engineers, developers, healthcare researchers, and medicine doctors who are striving to improve the healthcare experience better. We are driving cutting edge healthcare research, diving into real world scenarios to extract patterns of patient demand. And based upon the demand, we are started to analyze that what do we need to deliver to them. So we are focusing on contributing sustainable healthcare in UK, promoting intelligence, efficiency, and effective reach to the patient in this society. So the key consideration we've been through with this unexplained AI and healthcare support is the Life mobile app, which will help us out accessibility to different level, personalized experiences for each and every individual based upon our data mining technique. And we always go with effective communication and monitoring for collecting the data, only the required field, which is not the whole data, only the required data, and just connecting that with the EHR so that it will be a real-time integration. So our project aim that we have completed and submitted preliminary research includes the in-depth literature review and analysis of the key areas of improvement in this domain. So now we are looking for partners, those who can join us and make a license in this project. We are possibly looking for some ESRC fundings and need public support and researchers collaboration, for which we are actually open for. So according to our literature, we found that somewhere the total end-of-life related publications are 350,000 MDPI, and major contributions are USA, UK, anticipate in the role in end-of-life care needed for 2040s plus 25 to 42% requirement from now. So if we are going forward, we have studies on risk-association attitudes, which is actually the 150 studies, and we have end-of-life burden death is somewhere 29,385, which is again increasing 14.3% with rate. So finally, we came across that home death rate, as I discussed you earlier, which is yearly increasing somewhere by 4.3%. So what value does AI add into the palliative care is somewhere we are developing based upon a model-based approach, in which the model is over here. We need to improve this model. Again, this is just approach, and we are still striving to make it more improved approach with discussing and collaborating with other societies and other people, those who are working in this domain well before. So palliative care with AI is somewhere we develop a model, we collect the data from central data care centers, and then extract only the relevant information, as I told you earlier. Then we do some feature engineering, train the model and optimize it, develop the web apps, and finally deploying it. And that we believe that it will reduce the gap between the caregivers and the patient. So a prototype ad could be like the left side, we have developed a prototypes for this particular app, which is like warm welcoming a person, driving the mood, and then we are taking it today's focuses, discussing about upcoming in your circle. So what do you need to do? Is this the information which is readily required, not the old information? Again, this app actually deals with happy heart thing, which we actually made like not a welcoming, but a really warm welcoming to a person. And again, the health condition, the live chat, and the resource call for each and everything. What we are trying to do is making a unified app, which is actually all-in-one app, which has a seamless integration with healthcare systems, offline functionality. If you are out of the data network, it might work, but it will connect you with resource calling system. However, it will actually taking your information from happy heart health conditions as well. So again, if we believe that if there is some emergency situation need and you press a resource call over here, it will actually give an emergency call signal to your caregivers so that they can respond you well before time when you need it. So again, AI powered predictive support is also there. Digital advanced care planning tools we are looking for. Built-in emotional and spiritual support, especially for the uh, particular type of the people, particular clan of the people, regional, ethnic people. So they might not be been in a state of feeling some out of the society. This is somewhere what I have observed with the people with those who are HIV, that they become drowned in the HIV just because they think that they are no more be able to inculcate with the society or being connected with the society. So again, we are somewhere providing the digital advanced care planning and legal tools. And finally, I think so that's actually replicated. I'm really sorry. And finally, the secure communication with care teams so that they can be connected with the teams, those who are taking care of them. So that's the end of my session. If you have any question, we are still striving hard to get some good feedback. And if there are some still feedback, I'm open to those feedbacks.
Thank you very much, Said. Does anyone have any questions, please?
One of the things that gives problems in collecting data is that some people are much better at expressing themselves than others. And also, particularly for my generation, we tend to downplay any symptoms. It's instinctive and built into us. Further, if someone's stroke impaired, it makes life even more difficult. How are we going to try and address that sort of issue?
Habitually, we are looking for generating a questionnaire based of thing and generating a real-time experience with them, so that it's actually a win-win situation works when a person can be able to understand what type of information we are trying to extract. In some cases, like what you said, if I ask my mother, she's about 80, and if I ask that how you're feeling, she might not reveal all the pain and all the feelings which actually she has. So sometimes we have to ask not a direct question, we are asking somewhere indirect question or following the trend of the particular person. So if some vitals has been collected during a particular period of time, what we can do is we can involve those vitals to justify that the question which has to be replied by the particular patient, is it matching or not matching? So if it is not matching, we recurrently bring this information to the caregivers or the hospitals that we need to investigate that the particular readings what we are or the vitals we are getting doesn't match with the real record. Sometimes if we are doing some analog approach, sometimes we usually ignore those things. But being a digitalized approach, we might be able to help them out in comparative their previous trend compared to their current vitals, and then bring them a predictive analytics so that we can find that what is the gap actually between. I hope I understood your question well.
Thank you for that. Sorry, any other questions? All right, well, as I think of questions, I will ask one. When you reviewed existing apps, you did point out that one of the issues they've got is insensitivity to cultural and religious values. I'm just wondering, with the app you're proposing with unexplained AI, how is it going to address these issues?
Well, then it's a very nice question. I actually found that the first of all, the problem is somewhere, though the people or the elderly people, those who are here in the UK or well above the globally, they are not very much connected with the apps. So if we are bringing them the apps in their local regional language, the first step we are looking for making it a translatable app that can connect the people in their native language with the app, with the UI or UX. The second point is somewhere we are collecting some of the information from the hospital records or from the individual, those who are registering, and based upon those records, we are actually presenting all the questions which are relative to it. For example, if there's a person, those who's coming from any like a Hindu community, and then that's an example. So if we are saying it, so the app once open, it will say Happy Diwali or something, categorically looking for making it more familiar to the person, that the app is actually talking to me, making it more interactive. So our design is somewhere what we are perceiving is making the app more interactive based upon the data what we have collected, and customizing the app based upon the data to make it more personalized experience. So personalized experience is something missing. If you go and download any WhatsApp app or any other app, it's just a very generic or typical app. So the app doesn't have any personalized experience that what actually you would like to do. If I don't like the green button in the WhatsApp, I cannot do anything. This is my way. Again, for ethnic people, for a particular minorities, we still need to interrogate the thing that how better we can act. That's why I'm open to the suggestion, and I will go for all those people, for the doctors, for the medicine people, clinicians, to gather the information that what type of people are actually facing and what problems they actually usually report, that we need to take a care from a particular community or not, or we have to go for this type of care units or not, and why they are showing their priorities. So that works is actually under developing. That's why some of the features which actually I shared with you is still need to work hard, or we are still doing a brainstorming over it.
Thank you very much, Saeed.
Hi, I'm actually a clinician, and this has been quite an interesting topic. Thank you, Dr. Said. It's been quite informative as well. The only thing I was thinking about whilst you were talking about this was, does AI actually understand what it means for a human being to die in this? And furthermore, like, who would hold more responsibility if the AI informed decision leads to, like, for example, a premature withdrawal of treatment?
Yes, that is actually a really interesting debate about it. But actually we are not trying to deduce some decisions. We are helping the hospital people, the doctors, the caregivers as indicators. So we just provide the indicator that this might happen. We are not going to give a straightforward decision. Again, whenever the AI and the healthcare comes up in together to get I'm going to give a funny example. When AI is going to get married with the healthcare, the healthcare people always ask that, what if, how far will you go with it? Who's the decision responsible for what? Again, this is the same example that Tesla is developing a car which works autonomously. So we think that if a Tesla hits somebody, who's responsible? The person who has the Tesla, or the Tesla company, or the car? So who we can punish actually? But in this case, we are actually giving the indicators, the trends, not the decision. So a person, those who receive the trend, might be able to decide that what is the next action, or what is the next line of action a clinician should start with.
Right, thank you.
Any other question?
Yes, any other questions? All right, in the absence of any other questions, could we really
There's a
thank
question
you very
in the
much.
chat, I think so, Stephen
Sorry?
from IT. There is a Jan Basi, I'm sorry to interrupt you. There's a question in the chat, which is actually 4.3% rise in the home care death from 2019 to 2022. I wonder if there was something that happened in that period that reduced admission to the hospital. Again, during this period, pandemic is one of the biggest problem. Insufficient beds, people are already occupying the bed. That brings the health system to think about that either extending the number of the beds will be the only solution, or increasing the number of staff will be the only solution. So healthcare actually emerging or meaningfully looking for many things to discuss. And eventually they are expanding, but are not a very radical expanding, because if they expand radically, there might be that the demand might not be the same. And although the population has increased, so I personally believe as a predictive analytic that they have to expand. But there are something which we need to read from the literature, from the research, or from the records, that what are those trends. Still, we are striving to get some of the outcomes from this data, and we are on the go with it.
Yeah, I think Stephen is attributing this to COVID.
Yeah,
during that period. Yeah.
COVID actually generated a backlog queue of the people, those who are actually on a routine palliative care, having some routine checkups. So it actually increased the length of the waiting time, which is still we are facing.
All right. Last chance for a question for Dr. Saeed.
Yeah, just one more question. I'm so sorry to.
That's fine.
Yes. I just wanted to ask Dr. Saeed, are you aware of any other countries who have already implemented this or ahead of the UK in this that's actually working well for them?
Yes, I have discussed earlier in my apps that the apps are actually I think so 2 to 3 apps are actually limited to the USA. So they have developed their apps. Even now there is a portal on based on Australia, which actually providing a little bit connection between the caregivers and the patient. But I found that still that actually is not somewhere. It's actually not somewhere very much familiar. But America is actually working very hard over it. Still, we are far behind in providing. If we go with our NHS app, God forbid, like it's not up to the mark. If we are facing those difficulties, we have to move. We have to integrate the new systems into NHS app. That I personally think that it might lead to us to make a more sustainable palliative care design, or developing a framework for the people, those who actually need care, and making their experiences more better.